right. Well, thank you all for being here today. I think you heard my background is an OBGYN, but basically I just do addiction medicine this time and work with our addiction fellowship here at MAHEC. And this is a quick presentation really focusing on maternal toxicology, not on pediatric or neonatal testing. A lot of it's going to be reviewed for some of the clinicians in the audience. So I'm going to try to move quickly. Feel free to stop me during it if you have questions. So when we do drug testing, the important thing is to remember that this is just a tool and it gives us some information about the patient, right? But it's not a diagnostic tool. So absence or presence of a substance doesn't mean presence or absence of an addiction. And so we use this tool like any other tool to make decisions on patient care and hopefully to improve outcomes. The evidence for using drug testing in addiction medicine is actually pretty limited. Although there is some evidence that suggests when it's used consistently and in the correct fashion to monitor and adjust treatment plans, it can be beneficial for patient care. So when we do testing, there are two main categories we go into. So initially, right, presumptive testing, also known as screening test, qualitative. This is our point of care testing that we can do in the office, right? We get rapid results, but it has a lower sensitivity and specificity, but it's cheaper and quick. Versus definitive testing. So these are send outs for confirmation. So confirmatory tests, chromatography, mass spectrometry. A lot slower turnaround, but it's highly sensitive, very specific. It's giving you like a chemical fingerprint of the substance you're checking for. And when you see it, that's it. We're no more arguing of is it there or not. Anytime we do testing, there are four possible outcomes, right? Either it's positive or it's negative. And then if the substance that you're testing for is there or not, it's either a true positive or a false positive, false negative, true negative. Different studies that we can use have different times for detecting substances. So blood, breath testing, so like with alcohol, these are things we are going to use for acute intoxication because it's really going to give us minutes to hours of detection versus oral fluid testing, which we can do like in the opioid treatment program. If somebody has an indication for not being able to provide a urine, can give us minutes, but often goes up to 2 to 3 days, like urine drug testing. If you need longer testing, although evidence is definitely limited in addiction treatment with longer testing, there is sweat testing, which uses a patch and can detect substances for a couple of weeks. Full disclosure, I've never used that. I've never interpreted one of those. But it does exist. And then there's hair follicle testing, which I think I've seen more on SUV or NCIS, those shows than I've ever seen in actual medical practice, but can detect substances for up to 3 months. This is a very busy slide. I'm not going to go through it. It's really more here for your information and to go back and reference it if you just later on are just so excited and like, I want to look at that chart again. It's here. I also made it. So if you want to steal it and throw it in other things, feel free to do so. We really want to focus on urine drug screen because that's the most common one that we're going to use in the office, in the hospital, when we're taking care of our patients. So the basis of this is we're looking for metabolites, the breakdown products from substances that are ingested. And those can be detected in the urine typically about 2 hours after they're ingested because they have to be metabolized typically in liver, other body tissues, and then filtrated out into the urine before we can find it. Typical detection window, 1 to 3 days. Many things can affect that. We're going to go into that a little bit more detail here in a minute. The advantage of this is it's something we've been using for quite a while, right? So it's well established. Depending on which type of testing you're using, you can get rapid results. So right in the office, we can use our point of care testing. In the hospital, typically we can get results within a couple of hours. So it gives us a way to make some clinical decisions versus some other tests where we have to send out. If you have to wait multiple days, it's not really useful in the moment. Disadvantages, you can mess with sampling. So anybody who's done addiction treatment has probably encountered some urinary diversion at some point, right? It can also be adulterated. You can dilute it. So we have to do other testing with our urine drug samples to make sure that they're actually adequate. We test pH to look for adulterants. We're going to test specific gravity to make sure it's not too dilute. But this is invasive, right? At least in a treatment program, most of the time, patients are doing observed urine collections, which is very uncomfortable for the patient, which means you also have to have a staff member who's doing that collection and observation too. So with our urine testing, kind of sending it to the lab, or it would be our gold standard. It's got a little bit better precision and accuracy than the testing we can do in the office. Some things to look for on your lab. So when you see EIA, right, enzyme immunoassay, that's just another way of saying this is a presumptive or a qualitative test, screening test, versus LCMS, liquid chromatography, mass spectrometry. That's definitive, a quantitative testing there. That's the one that breaks it down into the chemical signature of the substance that you're looking for. If you're sending it out into your lab, unless you're in the hospital, right, you're going to get some delay in results. And even there, it's going to take a couple of hours. And that's versus point of care testing. So in the office here at Mayhec and my OTP, we do rapid testing with point of care tests. So this uses an enzyme immunoassay as well. You get rapid results. It's typically pretty cheap, lower accuracy and precision than the labs, but it's actually pretty good. And it's gotten better over the years. You do have to train your staff to interpret it. It's one of those fun tests for a lot of them. A line means negative, and we're so used to in medicine, we see a line that means positive. So we got to just some basic training, and you can get people to learn how to read them. If you've done enough urine drug testing, you may be aware that there are some limitations. One thing is your test only tests for what it tests for, right? Which is like a dumb statement, but it's so true. So it's very important when you're sending out a drug screen, you need to know what your lab is testing for. And more importantly, what is it not testing for? When I worked in Kentucky, I worked at a small hospital in Southeast Kentucky for many years, and our hospital screen didn't have buprenorphine in it. And I kept telling the hospital staff, listen, the most common thing that is being used illicitly in our community right now is buprenorphine because it's the most abundant. So when we do a drug screen and we don't have buprenorphine on there, we're really only doing it to make ourselves feel better. But if we're actually looking for any clinical value, we're not getting it. So it's important to know what you're getting and what you're not getting. The amount of use, the chronicity of use can affect the times that a given substance is detectable for a patient. And obviously there's potential for false positives and false negatives, right? So when we do a screening test or a presumptive test, right, it's really just a jumping off point. So let's go into the specifics of urine drug screens and look at some of the things that we typically test for. So most assays will have an opiate assay. The standard opiate assay is going to pick up morphine, it's going to pick up codeine, and since it picks up morphine, it's also going to pick up heroin, which is just diacetylmorphine. There are certain assays that you can look for 6-AM monoacetyl morphine, which is a breakdown product of heroin if you specifically are looking for that in the sample. It may, and I say may, detect hydrocodone, hydromorphone, which is breakdown product of hydrocodone. But you need specific assays for other semi-synthetic and synthetic opioids. I know for in our clinic, our point of care cups, while we test for oxycodone, will not pick up hydrocodone. So when I have patients on hydrocodone, I have to send that out if I'm going to try to detect it or not. And why is this? Well, it's because of what opioids are. So I understand this is probably a review for most people, but so when we talk, if you want to be correct, always use the term opioid. That's the overarching term. That is broken down into the naturally occurring opiates, which you get from the opium poppy: morphine, codeine, thebaine, which is we use to produce buprenorphine. So you can take codeine, you can chemically alter the structure, then you get your semi-synthetics, hydrocodone, oxycodone. I said buprenorphine from thebaine. And then methadone and fentanyl are actually purely synthetic. And that's why they require a specific assay. So if you don't test for methadone, you're not going to find it. If you don't test for fentanyl, you're not going to find. Benzodiazepines. So most assays, the cutoff is around 200 to 300 nanograms per mil, and that's actually lower than a lot of therapeutic doses. Most of them will detect nordiazepam, oxazepam. These are breakdown products, and chlordiazepoxide and diazepam or Valium. But a lot of the most commonly used benzodiazepines really react poorly with most standard assays. Clonazepam or Klonopin typically is not picked up in most benzo assays that I've used in the office or even send out in labs. So we have to actually send that specifically for definitive testing if we want to find. You may get Alprazolam or Xanax. You may not. Ativan, lorazepam. So, amphetamine screens. So, by far the most common one, you're going to get a false positive. I didn't put on here all the things that can trigger a false positive because a lot of things can trigger a false positive. Some screens will break it down into amphetamines and methamphetamines. Sometimes they just combine them. If you have a patient who is on Ritalin or methylphenidate, that's not going to be detected on a standard methamphetamine or amphetamine screen. You actually have to send that for separate testing. Cocaine, it detects the metabolite BZE. You can say that. I can't. I just mess it up. So it's like saying SSI. I can't say Social Security very well. And this is another thing that I have a hard time with. If you see a positive cocaine screen, it's cocaine. I have seen false positive, but it's such a unique assay that is pretty specific and sensitive for cocaine use. And marijuana. So marijuana detects delta 9 THC with the federally cutoff is around 50 nanograms per mil. There have been some case reports of CBD products triggering test. Now, with that, for a CBD product to be sold on the market, it has to have less than, I think, 0.1% THC, delta 9. It's also an industry that maybe is not the best regulated. So when patients are like, well, that's my CBD, I'm like, well, then you should probably stop using that one because it's got enough THC in it that it's causing you to have a positive or non-therapeutic screen. I'm not sure what it's like up in Johnson City area, but here in Asheville, besides getting your kratom at the grocery or at the gas station, now you can also get Delta 8 THC. I think I'm starting to see signs for Delta 10. So guess what? May not be picked up on these screens because we're specifically looking for Delta 9. So detection times. Now, this is an important thing to have a general grasp of and to also know the limitations when you're interpreting urine drug screens. So most amphetamine, methamphetamine screens, 1 to 3 days, could be a couple days longer. I've seen it up 3 to 5. Cocaine. Most things you want to look at are going to say 2 to 4 days and then it's out. However, with daily prolonged use, there are multiple case reports and some good data out there that says it can stay up there up to a little over 3 weeks. So you have somebody who is a frequent daily cocaine user. They stop using cocaine. 2 weeks later, they're still testing positive, and they're like adamant, "Hey, I'm not using cocaine," which I've had happen. Then that could go along with prolonged use. Now, the flip side of that is if you stop use eventually, it will be negative or therapeutic. And so that's what I tell my patients. And then eventually with continued cessation, it will resolve. I think most people are aware with marijuana, especially in pregnancy, infrequent use may stay in there 1 to 3 days, but if somebody's a daily user of marijuana, you're talking to a month, sometimes even a little bit longer before it's going to be out of someone's system. Benzodiazepines, mostly 1 to 3 days, can be up to 6 weeks with heavy use or with some of the longer acting benzos like Valium, diazepam. It can stay in there for quite a while. You have to monitor the metabolites. Opiates, right, which is just going to our morphine and codeine and thus heroin, a couple of days. Methadone, most things will say 2 to 11 days, buprenorphine 3 to 4. Now, with chronic use, my clinical experience is they stay in there much longer. Typically with buprenorphine, somebody's actually taking their buprenorphine daily and they miss 5 to 7 days, we'll still detect it. Same thing with methadone. People miss 10, 14 days, come back and still testing positive for methadone. Interestingly, so fentanyl. Here in Western North Carolina, and I'm going to guess that Eastern Tennessee is pretty similar. The most commonly opioid that's misused on the streets here is illicit fentanyl. What I was finding is I had patients who were stopping fentanyl use, had stopped for a couple of days, multiple days, and then we're still finding it in the urine. And so trying to kind of validate the patient story to what we were finding on testing. And recently, and I'm happy to share this article if anybody would like, and it's also listed at the end of this presentation, but there was a small study at an inpatient detox and rehab unit. So they took over 10 patients who were positive for fentanyl and the metabolite norfentanyl upon admission to this locked unit. And then they consented these patients to continue to repeat urine drug testing throughout their time on this locked unit. And what they found was it took on average almost 14 days before the norfentanyl was out of the patient's system. Not a couple of days. The data is saying 1 to 2 days for fentanyl to be out on a urine drug screen. That's based on our pharmaceutical grade fentanyl, typically at much lower doses than our patients are using on the street, and for a much shorter duration than our patients have been using the fentanyl that they're coming in to get treatment for. Very small study, but this goes along with what I've been seeing with my patients. And one individual in this study at day 21, when he was being discharged from this locked unit, was still testing positive for norfentanyl. So potentially they could stay in there for multiple weeks. Definitely have implications for patients who are in the hospital for a prolonged stay, for complications from IV substance use, and have repeat testing while they're there. And I've had that happen with, hey, this patient is positive for fentanyl. Well, were they positive on admission? Do we have levels? Because even 8 to 10 days out, that doesn't necessarily mean that they're using fentanyl in the hospital, unless you have some more testing to kind of corroborate that. Hair follicle testing I put in here because this is something that comes up for some of my patients, especially postpartum, when they're dealing with the Department of Social Services. And that's often where it's ordered. I've never ordered a hair follicle test. But the basics of this, as the hair follicle is growing around the base, it absorbs blood that passes through there and the sweat that gathers at the base. And it acts as this kind of continuous collection of substances if you have hair. So for me, I guess you can clip some chest hair if you have that as well. Body hair works as well. But it takes about 8 days for hair to grow from the follicle to the scalp. So, it takes a little bit of time. So you're not going to get something that was just used in the past couple of days on your testing. The other thing is a lot of chemical treatments can affect the results, right? Do you have hair dyeing? Have you had your hair permed? All those things could potentially affect the results of this testing, which can go out to 90 days, sometimes with body hair, maybe even a little bit more than that. So the advantage is this long detection window, right? You get a long history of substance use, and there's reduced tampering. You know where the hair came from because you watch the collection of it. It's expensive though, and the results really vary on the characteristics of the hair. Turns out if you have darker pigmented hair, you have more coarse hair, more textured hair, it's much more likely to retain a substance than if you have coarse, fine, and thinner hair. So the potential for discrimination in the results is definitely there. There are also case reports of passive internal contamination. So being in an environment with cocaine with methamphetamines could potentially lead to a positive result. The other thing is this process is not standardized. So as I was doing research for this and was pulling up articles, most of them are from pathologists, or legal. It's a lot of law-based arguments. Each lab has different processes for how they do chemically treat the hair to hopefully reduce this chance of external contamination, but without there being, nationwide lab standards, it's different from lab to lab, which means each lab also interprets the results. And it's never been recommended for addiction treatment because what are you going to do with that 3-month history? How does that change your treatment in the moment? So, but often get asked about it. So, all right, we just want to run through a real quick case just to show how wonderful urine drug testing can be and how exciting trying to get the results and interpret them correctly, how difficult that can be and how important that it is. So this is a patient of mine who is on methadone and high dose of methadone, but was also been struggling with benzodiazepine use, for which she went to inpatient treatment, was in inpatient treatment for over 2 weeks, came back to the office, and this is what we got on her screen. So you see, it's positive for methadone and metabolites. So she's taking her medicine. Awesome. And it was positive for benzos. So you see, this is a screening test. You can tell because my test actually says screening test by IA, immunoassay. So what are you going to do next? Well, the first thing is talk to the patient. It's this crazy concept where we say, hey, let's go over your results. Here's what we saw. And my patient said, yeah, I have not used benzodiazepines since I went to the inpatient treatment center. That was, several weeks ago. Okay, what are we going to do now? I said, let's send it for definitive testing. So send it off for liquid chromatography, mass spec, and here's what we find. So it's got these 3 things in it. What does that equal? That equals exposure to Valium. So Valium will break down, goes from diazepam, it breaks down into nordiazepam, temazepam, which then further break down into oxazepam. So we'll go back real quick. So initially, all 3 of these metabolites were present. A couple weeks later, send off another screen in the office, still positive for benzos. So we send it for confirmatory testing again, and here's what we find. So this was the first one on the left, right? And you'll see that the oxazepam levels increased significantly. They didn't even give me a number. They just said greater than 500. But the nordiazepam and temazepam levels were dropping. So at least in that point in time, that I can confirm no further use of Valium at that moment in time, right? So this goes along with a one-time Valium exposure. As the nordiazepam and temazepam levels come down, the oxazepam levels will go up, and eventually you'll just be stuck with that, and then you watch those levels come down. And for this particular patient, it only took about 6 weeks for it to get clear. Complicated by the fact that she was in some recovery housing where they were also doing testing, and they kept calling me saying, this patient is still positive for benzos. We don't want her on her methadone here. And I had to explain, well, let me tell you about the testing that we're doing. So drug testing, it's a tool, right? It's a tool that we use to treat our patient, and it has the potential to improve outcomes if we use it consistently and correctly. It's like parenting, right? Clear as kind. We want to do the same thing every time with every patient. There are advantages and limitations with each testing method, and depending on the clinical situation, right? Acute intoxication, yes, you may want a blood alcohol level. Is that helpful for a random screen when somebody just comes into your office? Probably not. And then presumptive testing. All presumptive testing needs to be confirmed. Now, you can do that in 2 ways. Hey, I see that your screen was positive for fentanyl. And the patient says, I used fentanyl. You just confirmed it. You're done. Or, I did not use fentanyl. I do not know how that got in there. Okay, great. We are going to support you by sending that off for liquid chromatography, mass spec, so we can confirm that this was a false positive result. So I always say, if you're going to do drug testing, 3 things, right? Does a drug test need to be ordered in this moment? What's the appropriate type of test needed for this situation? And then ask yourself, am I the correct person to order and interpret the results? Because I'll tell you, as physicians, I was ordering these tests long before I was actually qualified to interpret the results. We get no training on that. And it's much more nuanced than this. It's positive or negative. So that's all I got. Thank you all.
Fantastic. Thank you, Nathan. That was a really great overview of what seems to be something simple is really not that simple. So thank you for that. And Rick has been at it, sharing us some articles. And we did have someone join us during Nathan's talk. So I'm going to let you guys ask Nathan any questions, and then we'll get Christy to introduce in just a minute. What questions do you guys have for Nathan? Questions or comments?
Just a kind of a related question. Can you talk a minute about what we would see if we think that somebody has adulterated the point of care test? Like what are we looking for on confirmation for that?
So most point of care cups will have multiple indicators on them. So they'll look for urine creatinine. So if something looks off, it may be off. So we have had patients come and give a cup that's positive for buprenorphine in the office, but it's extremely, extremely clear, like the best hydration you've ever seen, and/or it also didn't have creatinine in it when we put it in our cup, which goes along with this isn't pee, and just some tap water that somebody had dissolved some of the buprenorphine in. So that's one thing. And they often will give you temperature. So have people who bring in other patients' urine or somebody else's urine, and it's cold. We're like, urine doesn't come out of your body at this temperature. So that's another one. And then pH is often on there. And if that's off, then you can send it for further testing. Interestingly enough, our point of care cups here, even in the OTB, do not have fentanyl on them. And as I said, fentanyl is by far the most common thing that we see in our community. So how useful is our point of care cup testing in the office? Not very useful. The problem is we don't have a CLIA waived point of care test for fentanyl that I know of that we've been able to get access to. There is fentanyl test strips, and they work great, but they're for forensic use only. So I have them in the clinic. We may or may not use them, and we just don't charge for them because we can't technically use them in our lab and charge for them. But it can give you an idea, do we need to send this one out for definitive testing or not? So you can get those. You just have to figure out how you do it without getting your clinic in trouble. Although if you're not using it to base your treatment decisions on, I think it's okay. And I can't believe that there's not a point of care cup now that has fentanyl on it. Some people have said, oh yeah, we've seen them, yet I've still not met anybody who's found one and used it. So.
What's a good source of information to gain further education on reading the testing like you're talking about?
So ASAM has produced a wonderful document, the appropriateness of clinical drug testing, and goes through the specifics of what you're looking for on the assay, possible false positives, false negatives, how do you interpret that? And it's a really good document that you can download from the ASAM website.
Perfect. Really good questions, guys. Thank you. Anyone else with a question for Nathan?
Well, I'll throw out a quick question to the group for people who are doing testing. How many are doing testing regularly for fentanyl? Show of hands. So I do on our send-outs, but.
Send-outs.
Is it on, I think it's probably on our send-out. Is it on our send-out, Joyce?
It is. It's on our
clinic. It's not in the cup.
And then how many are hearing from your patients with positive fentanyl? I have not used fentanyl in the past week or more, and then you're finding it on testing.
Ours have been, I used it 2 days ago.
And honestly, I haven't come across a lot of it. Methamphetamine is still the main thing that I'm finding on mine here in Bristol.
A lot of methamphetamines here as well. It's not uncommon that we find fentanyl as well in our patients who are not realizing that there's fentanyl in their methamphetamines. So even our patients that are using methamphetamines, we're saying, hey, do you have Narcan at home? Well, why would I need Narcan? I'm using methamphetamines. Like, well, yeah, predominantly, but sometimes there's a good chance you're going to get some fentanyl in there. Same thing with cocaine in our area. So anybody who's using any type of illicit drug, we're really encouraging them to get naloxone and keep it on them. I mean, there's been multiple stories over the past 6 months, out of California, actors, comedians who are overdosing and they're not using opioids that they knew of. It's cocaine, it's other things, but laced with fentanyl.